Good evening. My name is Mark Purnell, and I'm here to speak this evening on my experience with common biking injuries over the last 40 years or so of my practice as an orthopedist. Happy Cinco de Mayo, by the way, and just some things to get out of the way. A reminder that this is a series of lectures. This is one of a series of lectures once a month. The next lecture is by Chris George on June 2nd on treating joint pain with cartilage preservation and restoration procedures. So my intention this evening is to educate and inform people about common bicycling injuries. I have no intention of dissuading anyone from bicycling. I hope I don't scare anybody off of participating in cycling. I think cycling is one of the greatest attributes that we have in this valley. So we'll start out, what do these two bicyclists have in common? For those of you who don't know, that's Livingston on the, that's Armstrong on the left-hand side of the screen, and John Kerry on the right. In 2009, or participating in another race, Lance Armstrong broke his right clavicle. And for those of you who aren't accustomed to looking at x-rays, if you'll just look up and you'll see a red arrow on most of these slides. That'll indicate where the injury is. He was able to undergo fairly quick return to activities by having his clavicle fixed. And he actually finished third place in the Tour de France that year. John Kerry, when he was Secretary of State, sustained this periprosthetic fracture, or essentially a hip fracture, when he hit a curb while bicycling in France. He was a very avid cyclist, and he fell over and landed on his hip and broke just below where his total hip had been. He was put back together and got back to work as the Secretary of State, and he's currently the U.S. Special Presidential Envoy on climate. This is Paul David Hewson, for those of you who don't know him. This is Bono. In 2014, he collided with a pedestrian while riding in Central Park in New York City. And he sustained an orbital fracture, or a fracture of his eye socket, a scapular fracture, an open fracture of his elbow, and a fracture of his small finger. So all of these are relatively common injuries. Simon Cowell, this last year, broke his back when he was riding his e-bike. He said he hadn't read the instructions. The e-bike got away from him and did a wheelie. He landed on his back, and he had to have 6 hours of surgery to put his back together. The most severe injury you can have, obviously, is death. This was a supermodel back in 2006, and she fell off of her bicycle and was run over by a truck and died. This is by far the more common type of injuries that occur from cycling. George Bush was a very avid cyclist, and particularly mountain biking when he was president. And you can see the abrasions on his hand, his chin, and the black eye that he sustained. And I love his quotes. He said, when you ride hard on a mountain bike, sometimes you fall, otherwise you're not riding hard. And most of us can relate to that about mountain bike. We've had many presidents in the last 50 years or so that have ridden bicycles, from Jimmy to Joe. For those of you who are looking for Trump, he's not in there. Although he sponsored the Tour de Trump in 1989, this last year, a campaign speech, he said, "I'll never be riding a bicycle. I'm not getting hurt on a bike." He can lift a bike, but he won't sit down on one and ride it. So bike sales have increased dramatically in this last year, in the COVID year. If you look at the sales from January through April, from 2019 to 2020, there's been a dramatic increase in bike sales. If you look at the most dramatic, it's obviously stationary bicycles with the Peloton craze that's been going on. But there's a big increase in suspension bikes, leisure bikes, etc. And if you look at the total number of sales, the most dramatic one that's occurred has been in e-bikes. There's been a 190% increase in e-bikes. And they're not exactly the safest bikes in the world, as I already showed you with Simon Cowell. There's been a significant increase in sales. It really is an aid to people who want to commute by bike. And it's really beneficial for those older and less experienced bicyclists to allow them to get out and enjoy biking. On the other hand, there's a much higher rate of injury, particularly to the head and trunk with concussions and internal injuries. And most people feel this is due to the higher speeds. Some of these bikes are much larger and more powerful, particularly the one that Cowell injured himself on. And they have a higher incidence of collision with pedestrians. And one of the pros, it allows older, less experienced riders to ride these bikes. That's also a con because these people are older and less experienced and don't know how to handle a bike. I'm gonna let you read most of these quotes. I think they're kind of interesting. This is actually Albert Einstein in Santa Barbara in 1930. He spent a year out in Caltech between working out in Princeton. One of the significant benefits of cycling is it's a great aerobic exercise. It's a low impact exercise, and by that it doesn't have a lot of eccentric exercise to it. It has mostly concentric. Concentric is when the muscle shortens and also contracts at the same time. Concentric is what you do when you run or you go downhill, and that's when the muscle contracts and lengthens at the same time. And it's much easier to adjust intensity. So it's much easier on the joints, and it's also easier to adjust your intensity. You can just slow down if you need to. Another quote from George Bush. He said, "Nothing compares to getting your heart rate up to 107 something, riding hard for an hour and 20, getting off and not hurting as opposed to 24 minutes of running, at the end of which I hurt." I think that's with his Secret Service support there in the back. A huge benefit of cycling is what's now being termed micromobility. And that's to use cycling for transportation. It's a very low carbon transportation source. It has a much lower infrastructure need. And all you need to do is look at the difference between the bike path from here up valley compared to the Highway 82 to tell the difference in the infrastructure. It's much healthier and better to commute than by car or bus. And you're not only benefiting yourself, but you're benefiting your whole community in the world by decreasing your carbon footprint. And it's fun. John Kennedy said, "Nothing compares to the simple pleasure of a bike ride." And it's integral to our community here. Many of us enjoy biking. And that's actually me down in the right-hand corner after I finished La Ruta de los Conquistadores in Costa Rica in 2002. I'm actually smiling at that time. My biking experience, I started like most people did back in the day. I started out with a Schwinn balloon tire bike, worked my way up through a 3-speed, a Stingray, a 10-speed road bike as an alternative to running injuries, etc. I really took it up as an off-season training for cross-country skiing while I was in Madison, Wisconsin during my residency. And I took up mountain biking in the Roaring Fork Valley in 1984, and I started the USA mountain biking team physician program in 1995, and I was a team physician for 20 years, attending the World Championships, and that's actually me in the upper left-hand corner with the hat on. This is part of the mountain biking World Championship team in Austria in 2012. The first injury I had was I knocked out my front teeth when I was 5 years of age. I didn't know how to use the brakes on the bike. I went too fast and I ran into a parked car and lost all my teeth in the front. I got back on the bike. I've had my share of abrasions and sprains, and even had a mild concussion once when I fell off the bike trying to jump over a log. I was wearing a helmet, so it was pretty mild. The most serious injury I had was a compression fracture of T6 in 1999. Again, I was riding too fast. I was trying to keep up with someone who was a lot better than I was. did an endo and landed on my back and broke my back. I did what I probably would never recommend to my patients. I got back on my bike, rode down, and was back riding for exercise within a week. So I'm going to talk a little bit about bicycling injuries, talk about the epidemiology, how they happen. We'll talk about common injuries, fractures, etc. And then I'll talk a little bit about overuse injuries. According to the CDC in 2010, there were over 500,000 bike admissions to the emergency room in the United States. And that resulted in 1.2 million doctor visits. 50% were less than 20 years of age. So this is nationwide, at least. It's a young person's sport to be injured on. And I'll show you our data here from the Forearm Fracture Valley a little bit. It's a little different compared to what it is in the rest of the country. But there is a significant incidence of traumatic brain injury admissions, and it's really quite a bit higher than many other sports. And that doesn't even include all the unreported injuries. I've never reported any of my injuries to the CDC or presented to the emergency room. And I know a lot of other people don't. It's estimated that there are 37.5 injuries per 100,000 in the population from bicycling. And its incidence is second only to riding animals in its severity of injury. The risk factors for biking, males are much more common to injure themselves than females, 2 to 3 times. Again, nationwide, younger riders are more commonly injured than older, and that's, again, a little different than here in our experience in the Valley. Peak age for injury is 9 to 14 years of age. The incidence of injuries is much higher in mountain bikers than road bikers. And in one series, 85% of the mountain bike competitors in the United States were injured in a given year. The severity, on the other hand, is much higher for road bikes than mountain bikes. And the reason for that is primarily cars and speed. And at least in the past, helmet use in mountain bikers has been greater than road bikers. And obviously, if you ride more, you're more likely to injure yourself. This was a questionnaire performed in California in the 1990s, and they sent it out to 3 different mountain biking clubs. And the incidence of injuries was 90% trunk and extremity injuries. 37% of the respondents had trunk injuries. 12% had head and neck. But the vast majority of these, almost 70%, were relatively mild, with most having no treatment or self-treatment. About 25% of them sought care with a physician. 14% ended up in a hospital, ER, and 4% were hospitalized. The reasons for these injuries varied, primarily excessive speed, unfamiliar terrain, inattentiveness, and riding beyond their ability. But even 7% had equipment failure, and I've had injuries from equipment failure, and I've actually seen bicycles fall apart like that one in the middle there, where the forks flew off. There's a relatively low incidence of injuries occurring because of drugs or alcohol. Now that's going to be different, you'll see in the future with fatalities, but at least for most mountain bikers, it's relatively low. In this valley, we looked at our ER patient visits, and we collected over a 2-year period about 478 ER visits. The vast majority were outpatient, a few were inpatients, some of them required surgery. Again, the majority of them, almost double, were male. But you can see that the age was 31 years. So that's significantly different from nationwide. We have an older patient population that are out riding on a regular basis. We had no deaths during that period of time. The vast majority of injuries were either lacerations or abrasions and contusions. There were still a significant number of fractures, sprains, and dislocations. 21 out of 478 concussions, or 4%, and then 29 miscellaneous things. By body part, again, the majority were upper extremity, 50%, and 23% were head and neck. So it's primarily the upper body that gets injured from cycling. There were still any number of lower extremity injury and chest and abdomen injuries, made up about 10%, and those can be significant injuries. I'll show you. Here's an example of this patient. If you look at all those arrows, those are all rib fractures and clavicle fractures. When you have that many injuries, you are bound to have other injuries, and a number of these, although not high, had significant internal injuries with a pneumothorax, liver laceration, kidney laceration, and one genital injury. These genital injuries are actually fairly common where you have a lot of people who are riding BMX for some reason. Of the fractures, again, the majority were upper extremity, a few lower extremity, and again, chest, head, and face with 3 spine injuries. The clavicle, by far and away, is the most commonly injured upper extremity bone, but there were a number of wrist fractures, radial head fractures, and I'll show you what these are later in the talk, a couple of hand and miscellaneous. Lower extremity, the hip is actually not infrequently injured. When you land on your hip, you can break your hip biking, either at high speed or low speed, and I'll talk about those a little bit. Tibia and fibula fractures, ankle fractures, pelvic and foot fractures also can occur. And then again, a few spine fractures. And unfortunately, that red arrow is right over where the fracture is. But that's about what my fracture looked like. I had a 50% compression fracture of T6. Some of them could be injured, some of these fairly significant. One had a central cord syndrome and one was paraplegic. I didn't have any neurologic issues with mine. The chest and trunk injuries, again, can be fairly significant. The vast majority of them weren't significant, but we had several pneumothoraces, a liver laceration, kidney laceration. That red arrow is actually pointing to a laceration of the spleen right there. That's the spleen, here's the stomach, and that's the liver. Again, head and neck can also occur. 50 Cent didn't like his bike being stolen. So the Department of Transportation reviewed traumatic deaths from cycling in 2013. And they had collected about 741 deaths. Now this was significantly less than 1975, but it's been fairly flat over the last 20, 30 years or so. 84% of these were in cyclists older than 20 years of age. Again, the vast majority were male. The vast majority of injury-causing deaths was head injury. 66% were not wearing a helmet, and 90% involved a car versus cyclist, with 40% of them being struck behind. As I said before, in mountain biking, the incidence of blood alcohol contributing to injury was pretty low, but in fatalities, it's actually much higher. Almost 20% of the cyclists had a blood alcohol greater than 0.08%, and 30% of the drivers had significant blood alcohol. This picture is actually from a bike race that occurred in Monterrey, Mexico in 2008. I think a half a dozen people were killed during this race. The driver was drunk, he fell asleep, and he slammed into the peloton of bikers. So what's the most dangerous state to go cycling in? Well, if you go by annual deaths per million residents, it's Florida, hands down. It's almost twice the next closest one in risk for death. The total number is, the highest number is in California, with 338 during those 2 years in 2011, 2013. Where does Colorado sit? Well, it's down here at number 14. During that time frame, 29 people were killed on roads, cycling hit by a car. And that's almost 3 times less than the deaths per million residents in Florida. Where's the safest place to ride? Well, it's up here in Maine. I don't think they had any of that, period. How does this compare to other risks of death from motor vehicles? Well, in 2014, 726 cyclists died in motor vehicle accidents, compared to 32,000 in cars, and 4,884 pedestrians were killed by cars during the same period of time. The incidence of people dying from motor vehicle accidents has gone down significantly from 94 to 2012. That's the green line up there. And again, as I said before, from 94 to 2012, the number of bicyclists dying from motor vehicle crashes has been pretty flat. Where do people get injured by cars when they're riding a bike? Well, 45% occur at intersections. This is where cars are turning or trying to get across. They don't see the cyclist. They cut in front of them. They run into them from the side. 40%, again, of the cyclists were hit from behind, with a failure to yield being the cause of most of them. And although studies vary widely, it's estimated that the fault is about 50-50 for the bike versus the car. For those of you who are interested in how to mitigate the risk of bike versus cars in cities, this is an excellent film from 2015. It looks at bike versus car accidents in a number of different cities throughout the world, and how cities can mitigate the risk to cyclists. I've watched it. It really is a fascinating film, and really has a lot of good points to how to decrease the risk of bicyclists from cars. Does helmet use help? Well, a lot of studies say it does. According to helmet.org, the use of a helmet reduces the risk of head injury by about 85%. Cochrane meta-analysis looking at a number of different studies thought that it provided about 63 to 80% reduction in the risk of head and brain injuries. But if you believe the New Zealanders, it didn't seem to make a whole lot of difference. So beyond death and head injuries, I'm going to talk a little about contusions, laceration, abrasions, and fractures. A contusion is caused by a direct blow causing tissue crushing or tearing and bleeding. It's commonly known as a bruise, and you can bruise any number of tissues: skin, fat, subcutaneous tissues, muscle, and bone. On the top there, that's obviously a bruise in somebody's thigh. On the bottom, if you look at that red arrow, that's pointing to an area of contusion involving the end of the femur. That area of bone is what we call spongy bone or cancellous bone, and it can be bruised just like any other tissue in the body. The vast majority of these injuries are minor. They can hurt quite a bit, particularly if you hit it hard enough to bruise your bone, but they'll usually heal without significant problems. Occasionally, you can have a severe injury, particularly if you have a contusion involving the compartments of the calf. You can develop a compartment syndrome where the pressure gets too great. The typical treatment for contusion is the typical rest, ice, compression, and over-the-counter non-steroidal anti-inflammatory medications. There's one particularly disconcerting injury that can occur from a contusion, and that's a shearing injury about the hip over the greater trochanter. And this is a picture of what these lesions can look like. It's named after Dr. Morel Levayer. And what happens in these situations is opposed to a direct blow, there's a blow with a shearing injury. It actually breaks the tissue away, the subcutaneous tissues away from the underlying fascia, and it creates this pocket that you can bleed into. And they look like you have big saddlebags on your hip, and it really is very disconcerting to the patients. You can see how big that collection of fluid is. That's that white collection there underneath the skin and right next to the femur and above the muscle there. They almost always will resolve spontaneously, but they can take months and they can be quite unsightly. Most of the time we advise people just leave them alone, let them go away by themselves. Very few of them may require drainage and antibiotics. If you do have to open them and drain them, they're much more likely to get infected though, and that can be a real problem. Lacerations can involve not only the skin, but it can go down from the epidermis into the dermis, the subcutaneous tissues, the subcutaneous fat, etc., the fascia overlying the muscle and down into the muscle and tendon. And obviously the healing is dependent on the depth and extent of laceration. Most of the time we want to approximate the edges of the wounds to get them to heal. We want to remove any contamination and minimize the risk of infection. This is much harder to do over areas of motion such as the knee and the elbow. The treatment is typically to clean it with soap and water. Soap and water is the best thing you can use to get rid of contamination and bacteria. If it's very superficial, such as in the epidermis, just tape the area closed and then put a dressing on it. If it gets down into the dermis, into the subcutaneous tissues, particularly into the muscle, etc., it may require, well, obviously it will require some type of suturing to put everything back together again. But it's wise just to keep it clean, cover it, and seek medical care. And always remember to check on your tetanus status and get a tetanus shot if you haven't had one recently. Puncture wounds are another one that can occur. This primarily occurs in mountain bikers when they run into a branch or a stick. It's obviously important to remove the foreign body, clean it thoroughly, don't close it. You don't want to close these things, you want to let anything come out. And again, this is where you really need to be aware of what your tetanus status is. And again, injuries around the areas of motion, the joints, the elbow and the knee, have what are called bursas. These bursas are where motion occurs. It's a potential space. If you have an injury to these areas and you have foreign material that gets into these big open, big potential spaces, that can get infected. So they need to be thoroughly cleaned. Frequently, they need to have a drain put in them, and again, check your tetanus, and frequently they'll need antibiotics in addition. Abrasions are what we call road rash, and that's probably the most common injury that occurs in cyclists. And again, the healing is dependent on the size, the depth, contamination, and whether it occurs over an area of motion or not, with areas of motion being much more difficult to manage. Again, the treatment is to thoroughly clean them, and I would recommend you do this as soon as you can. Do it before the inflammatory phase starts. If you wait until the inflammatory phase gets going, that can occur 12, 24 hours after the injury. It'll be much more painful to try and clean them out. Again, use soap and water and scrub thoroughly to remove any debris and dead skin that is in the area of abrasion. A lot of people like to put hydrogen peroxide on these wounds, and like to see it bubble up and feel that it cleans the skin and is an antibacterial agent. It is an antibacterial agent. It'll kill bacteria, but it also kills the cells that you need to heal. So it's okay to do it once. Most people now recommend you don't do it at all, but it's okay to do it once, but don't do it after that. If you keep doing it after that, you're going to kill the very cells that you're depending on to actually heal the wound. You can use an antibiotic ointment to keep the skin moist. That's really what it's for. The antibiotics in the ointment are an added benefit. You could just as easily use Vaseline or something like that to keep the skin moist, but you really want to keep that skin moist to let those cells again grow in. Cover the area of abrasion with a clean dressing, and again, limit motion. And again, check your tetanus status. It's not as critical in these, but it still is something that you need to check on. Seek medical care if you have an extensive abrasion. If you have embedded dirt and it's just too painful to clean, if there's exposed subcutaneous tissues, or if it involves a bursa. Fractures occur when you hit hard enough to break a bone, and it's really dependent on what hits the ground first. And typically in cycling, it's going to be an upper extremity that's going to hit the ground before the lower extremity. When the lower extremity does hit first, well, that can be kind of catastrophic. Navicular fracture is an injury that is actually quite common. I just saw one a couple of days ago in a teenager who was involved in a bike race that's barely visible on the x-ray. The navicular is one of the most difficult bones in the wrist to get to heal. And it's really crucial bridging between the proximal and distal row of the carpal bones. A non-displaced fracture needs to be treated very aggressively with immobilization and then followed very closely. Even if you suspect a fracture but can't see one, you still ought to treat it as a fracture, and we frequently do this and cast them for a period of time until we're absolutely sure that the navicular isn't broken. And any fracture that is displaced should be fixed. And now we do that with a screw. And they typically will heal once we fix them. A non-displaced wrist fracture, here we're talking about a fracture of the distal radius. Anything that's non-displaced, again, needs to be casted, and sometimes we need to reduce these and cast them. Usually takes about 6 weeks. And during that period of time, with either a navicular fracture or a wrist fracture, typically we can get you back on the bike during that phase. And frequently I'll have the patient with the injured extremity bring their bike in so we can mold it to their handlebars. And a lot of people get back and enjoy biking during the casting phase. Pediatric fractures this is a very common injury in kids in cycling. And people get a little confused. You can have a fracture involving the growth plate, and those are much more significant typically, except for the very minor ones. You can also have what's called a green stick fracture, and it is what it sounds like. If you try and break a green stick, usually you'll crack on one side and then bend on the other. But then there's another fracture that most people don't know about. It's called a buckle fracture or a Torres fracture, and this is actually more common in kids than a green stick fracture. And this is kind of analogous. If you take the tube out of the inside of a roll of paper towels and try and break that, it'll buckle or bend on one side. And that's what can happen in kids too. An adult would never get this because we're far too brittle, but a kid can actually buckle. These fractures, buckle fractures, are very easy to manage and cast. The green stick fractures are a little bit more difficult because they can spring back. We have to be careful to over-reduce them and then cast them and then follow them closely. If you have an unstable fracture, this is where we need to put them back in place and then fix them, as shown in this x-ray on the right-hand side there. Again, those fractures, once they're fixed, we can put you in a cast and get you back on the bike. This was an interesting patient that I had several years ago. She fell 10 days before she was scheduled to ride in the Leadville 100 and sustained this fracture of her radius. These need to be fixed. If you don't fix them, they can angulate, and then they can also bridge and limit your ability to pronate and supinate your arm. So I agreed to fix this and put a plate on it. And even though I didn't recommend it, she was able to ride significant portions of the Leadville 100 that year. Again, I wouldn't recommend it. We made her a brace to protect her, and she didn't do all of the race, but she was able to do much of it even 10 days after the injury. Radial head fractures are injuries that occur at the elbow, and they usually occur when you land on your wrist, not on your elbow. The radial head is this bone right here. That's the bone that allows you to pronate and supinate your hand in space. And if you have a fracture there, it's quite painful. Most people come in with significant limitation of range of motion, and they're very uncomfortable. Sometimes it's very difficult to see them on an x-ray. You can just barely see a little crack right there. Usually what we want to do in that situation is just protect them for a couple of days, make them comfortable with a sling, and then really get them moving very, very quickly and limit their stress to that area. Unfortunately, this is not one of the ones where we can get you back on a bike really quickly. The biggest problem with these fractures is limitation of motion if you immobilize them too long. Sometimes if they're displaced, you have to fix them. And if they're really badly injured, you have to replace them. There's this one on the lower right-hand side. The olecranon is where the triceps inserts into the ulna. And if you break that, you are completely unable to straighten your elbow actively. So these all have to be fixed. This is the type of injury that occurs when you land on your elbow, not on your hand. This patient presented and was unable to actively extend. We fixed them by putting a plate on it and got them moving right away. Again, this is not one of the injuries where you can get back on your bike right away. Clavicle fracture, again, is the most common upper extremity fracture that occurs in cycling. If it's a minimally displaced fracture, such as this one on the upper right-hand side in a pediatric patient, those can be managed quite successfully with a sling and sometimes with a figure 8. If they're significantly angulated, like the one in the lower right-hand side, those usually we recommend that they have them fixed. Any type of shortening in that situation will lead to difficulty healing and frequently shoulder issues in the future. So here's one that we fixed. You can see the fracture here at the distal clavicle. Put a plate on that, and the patient was able to get moving that shoulder right away. Again, although some people will get it back on their bike and active right away, it's not recommended. Sometimes clavicle fractures are associated with very severe trunk fractures. So this is that patient that I showed you with the 8 rib fractures. And if you look at this chest, this is the normal left side of the chest, and this is the caved in chest injury on the opposite side. And they have a hemopneumothorax as well as subcutaneous emphysema from air leaking out, plus this clavicle fracture. If you look here, these are all the fractures that this patient had. This was a single bike accident coming down from Ashcroft, and it was unwitnessed, so nobody knows exactly what happened to this patient, but he obviously sustained a fairly traumatic high-speed injury. This patient, as you can imagine, with all of the underlying lung problem, was in really dire straits. And so we did something a little bit unusual with him. He was unable to use his right chest wall at all for breathing. And so we knew we had to stabilize his clavicle so that he could use the muscles of his clavicle, but we also needed to stabilize his ribs. So we actually put plates on multiple ribs as well as his clavicle, and made a huge difference in his healing and got back to activities. Took him a while afterwards, but we were able to actually save his life in that situation. As I said before, hip fractures are not all that uncommon in the lower extremity from cycling, and they occur in very predictable ways. You can have either a low speed injury, which is a low energy injury like this one on top, or you can have a high speed injury like this one down below, which is a subtrope intertrope. This one on top is a femoral neck fracture, but almost all of these will require that they be fixed. This fracture on the top again is a low speed injury that occurred in a gentleman who was biking while exercising. He had a clavicle fracture as well as a hip fracture. And as I said, you need to reduce these and fix them. Otherwise, they either won't heal or they can go on to what's called avascular necrosis, where this portion of the hip actually dies from lack of blood supply. Or they'll heal in a shortened position, in which case it makes it difficult to walk. So we fixed that with a number of screws. This patient, you can just barely see this intertrochanteric fracture up here, this little line. This patient came to a stop while he was clipped in to his pedals, and he was unable to unclip when he came to a stop. He fell over onto his left side. His left hip was the first thing to hit the ground, and that's the thing that broke. And again, this is a common mechanism of injury. Someone comes to a full stop, they can't get their foot out of their clip or out of their pedal, and they land on that side and break the hip. He was unable to walk, and so he was brought to the ER and diagnosed and fixed. On the other hand, some patients, if they're fit enough, young enough, etc., can have a hip fracture and not know it. This was a 27-year-old male, fell at the pump track in Mid-Valley, and he noticed that he had significant pain in his hip. He actually drove himself to the clinic, and we were able to diagnose him right away. His mechanism of injury was classic. His location of pain was classic, and again, we could see it on an x-ray. So again, this is, even though it doesn't look like much, if we don't fix this, he could potentially have this fall off and then lose blood supply and not heal properly. And obviously, if you have much higher injury, you can have a much more severe injury. This is a femur fracture that occurred in a lady that fell mountain biking on Government Trail. Took them 6 hours to get her out. All of this other stuff up here is just dirt and rocks that were incorporated into her shorts and things. She had this femur fracture. They look horrible, they feel horrible, they're very traumatic, but we can fix them with an intermedullary nail and get them up and get them going fairly quickly. And then you can get fracture of the ankle. This is probably one of the more severe ones that I've seen. Again, this was an injury that occurred on Government Trail. The 74-year-old put her foot down when she was traveling at a high speed, sustained a rotational injury, and had this fracture, which we fixed. She had a prolonged recovery from this injury. We'll go on to some common overuse injuries, and then we'll open it up for questions. And I'll talk primarily about neck and back injuries, and talk about the difference between localized pain and radicular and neurogenic pain. Upper extremity, primarily talking about compression injuries about the hand, and then lower extremity overuse problems that occur about the knee, and about the knee and the foot. So neck and back pain are very common in cyclists, and we like to differentiate them between localized pain, so pain that involves the neck or the back, and then radicular pain that occurs when you have a pinched nerve. In localized pain, the pain is going to be about the neck and the back. In radicular pain, you're going to have pain in the arms or in the legs. So most neck and back pain is due to weakness or fatigue that occurs from being a cyclist in the bent position with your head up. The average human head weighs about 5 kilograms, and if you have to hold it up all the time during a ride for 2 to 5 hours, it can be quite fatiguing and cause pain. Core strength in the lower extremity also, in the lower back, can also come into play. You need your back muscles to stabilize your pelvis on the saddle. If you don't have those muscles to stabilize the pelvis, you can't utilize your legs to pedal. So you're constantly using your neck muscles and your back muscles to stabilize your body on the bike. So an upright posture can lessen the strain for both of those, and core strength can dramatically improve your tolerance to those pains. Radicular pain occurs when the nerves get pinched. And this primarily occurs in the neck. When you put your head back, the facet joints are compressed, and the foramen, where the nerve roots come out, also can get compressed. And if you have underlying disc disease and you have osteophyte formation about these facet joints in the back, you can get pain from pinching the nerve, and that pain again goes out into the hand and arm with very notable distributions. The most common being C6 going out into the thumb and index finger, and C7 going out in the middle of the hand. Here's a patient that presented with pain in his neck. He had been riding up to the Maroon Bells, and he had radicular pain going out into the hand, but he also had weakness of his legs. And the other thing that we did, we checked his proprioception, his ability to control his upper extremities. He was unable to touch his nose with his eye closed, signifying that there was probably something much more significant going on in this gentleman. So it's important when you see these patients not to just look at these areas of disc disease. He actually had a tumor in his brain that we found when we imaged his brain in an MRI in addition. So the other neurologic compression that can occur is in the hand. The median nerve is at the wrist, and it goes through the carpal canal. And it gets pinched when you are riding on the upper portion of a road bike handlebar, or commonly on a mountain bike handlebar. And that primarily involves the distribution of sensation involving the thumb, index, and long finger, and part of the ring finger. The ulnar nerve can also get compressed at Guillen's canal on the side of the little finger. And both of these things can occur, and I've actually experienced both of them from riding. The way to manage this is frequently change position on your handlebars. Padding can sometimes be helpful, using padded bike gloves. Bar ends can be helpful on mountain bikes. Having a much more upright position on your bike can also be helpful. You can try different bars. And occasionally you have to release the nerve, primarily carpal tunnel release, to allow patients to get back cycling again. Lower extremity overuse syndromes primarily include the knee. And the knee is the engine that makes your bike go, and it's the most commonly overused joint. As Jan Voigt said, when my legs hurt, I say, shut up legs and do what I tell you to do now. I would never tell a patient to do that, but Jan's been doing very well with it. The overuse areas are primarily the extensor tendon, either the patella or the quadriceps tendon. You can get a tendonitis or a tendinosis. If you have issues with the cartilage behind the kneecap, you can have chondromalacia patella. You can have hamstring tendonitis, either on the medial side or the lateral side. You can also have an iliotibial band syndrome occurring on the lateral side. And on the medial side, you can have what's called a medial plicus syndrome. So the way you know you have a tendonitis is obviously you have knee pain with overuse. Usually there'll be tenderness either on the proximal pole of the patella or the distal pole of the patella. It'll increase with intensity. People with malalignment that have a big Q angle or have varus legs or bow-legged legs can have problems. And people who are very tight can have significant issues too. The stronger your core is, the more likely you use your back and gluteal muscles to power your legs, and the less likely you are to use your quadriceps or be quad dominant. And pedal float can actually play a significant role in knee pain. If you have pedals that have a lot of float, then you have to use your hamstrings in order to stabilize your foot on the pedal. If you have no float and the pedal is malaligned, then you can put a lot more stress on the knee while you're riding. So the treatment is going to be relative rest. By relative rest, I mean, don't stop doing everything, but cut way back on the activities that are causing problems. You can use over-the-counter non-steroidals, but only use them for short term. If you have to be using them long term, you're really not doing yourself any good and you're not benefiting the tendonitis. Usually when it gets to be a long-term problem, it's not a tendonitis anymore, it's a tendinosis, where you actually have the injury to the tendon structure itself. Stretching can be very helpful. As I said before, core strengthening is essential. Eccentric training can be quite beneficial. Usually I like to recommend that if you're going to be doing eccentric training, you do that under the supervision of a trainer or a physical therapist. And then you can do a lot of it on your own. Obviously, bite fit and orthotics can also be helpful. Iliotibial band syndrome is not uncommon in the cyclists, and it usually presents with a very sharp pain over the lateral aspect of the knee. The iliotibial band is this big tendinous-like structure that goes from the gluteus maximus and the tensor fascia lata here up in the hip and goes all the way down and attaches to the tibia. And it can rub in two locations. One is over the greater trochanter, the other is over the lateral albicondyle. And again, it can present as a very sharp pain. It feels like someone's stabbing you in the side of your knee with every rotation on the bicycle. Usually only occurs once you've been cycling for a while. It's typically relieved by rest, and it's usually associated with a tight iliotibial band and gluteal weakness. The treatment is typically going to be a period of relative rest, a course of stretching of the gluteal muscles and the iliotibial band, core strengthening. A lot of people swear by foam rollers. Non-steroidals can be helpful. Sometimes an injection of corticosteroid can be very beneficial, both in the diagnosis as well as treatment. And I almost always send people to a physical therapist because it's very difficult to learn how to stretch your IT band all by yourself. Medial plica syndrome is something that most people don't know about. There's actually this little infolding on the inside of the knee, and it can rub back and forth over the medial condyle. It's quite unusual from cycling. It usually occurs in other things like just kneeling for long periods of time. I've seen it in a teenage catcher who had to kneel and stress that area. It again occurs with activity. There's increased pain with each rotation or revolution on the bicycle pedals. It's improved with rest, and it's made by a diagnosis of exclusion. This is what it looks like in arthroscopy. Here's the femoral condyle. The kneecap is up here on top, and this little band rubs back and forth. Occasionally, we have to remove those arthroscopically, but usually people get back right away. We'll frequently treat them initially by rest, sometimes do an injection, but as I said, if they persist and we can't get them to go away on their own, we have to take them out arthroscopically. So on to the final area of overuse injuries, the foot. A lot of people will come in and say that they have a hot spot on the bottom of their foot, right over where the metatarsal heads push into the pedal. And the differential is typically either metatarsalgia or a Morton's neuroma. Now in metatarsalgia, it's the metatarsal heads and the metatarsal phalangeal joint that is putting pressure onto the pedal surface through the shoe. And again, people present saying that they have a hot spot on their foot. And I've had these any number of times cycling for long periods of time. The treatment is usually by using orthotic, and we can frequently get away with just using a very simple foam pad as shown here on the lower right-hand side. If necessary, we can have custom-made orthotics made, and they can really be beneficial for a lot of people. Adding an arch support, again, distributes load away from that area and improves the situation considerably. And then Morton's neuroma occurs with overuse causing pressure on the common digital nerve as it comes out between the two metatarsal heads. It usually shows up as pain very similar to metatarsalgia, but in addition, frequently they'll have a feeling of a lump or a ball in the foot, and sometimes they'll have numbness from the injury to the nerve. Again, we're going to try and treat these conservatively using a wider shoebox, using an orthotic, an arch support, a metatarsal pad. Not infrequently, we'll try an injection of corticosteroid into those areas, which can be quite helpful. And occasionally people need surgery. So overuse injury and prevention. Start with a bike fit. Make sure you get the appropriate bike, the appropriate fit. You're not bending over too much. You're not too far back on the seat, or you're not too far forward. Generally speaking, the farther forward you're going to be on the seat, the more you're going to be utilizing your quadriceps for pedaling. The farther back, you're going to be adding your gluteals in addition, utilizing your core strength to aid in pedaling. And that's usually a better situation for people who have significant knee pain and have quad dominance. It's really important to train smart. Ride, rest, and recover. So it's during this rest and recover phase that we actually get stronger. If you don't give yourself enough time to rest and recover, then you're going to set yourself up for overuse problems. We put on all the collagen and increased muscle mass during this rest and recovery phase. You want to give yourself time to do that. Stretch. A lot of people like to stretch beforehand, but the best time to stretch is actually after you do the activity. And again, as I said, footbeds for both the knee and foot can be quite beneficial. And as I said before, train off the bike. Get your core strong. The stronger your core is, the less quad dominant you'll be, the less likely you are to have significant back or neck issues when you start biking in the spring and summer. And as Freddie Mercury said, we all want to ride our bicycles. We want to ride them wherever we like. And finally, stay safe. Wear a helmet. Wear a helmet. Avoid cars. Ride like the cars can't see you, because frequently they can't, and you have no control over what they're going to do. And as I said before, 40% of significant injuries occur when a car hits you from behind and you can't even see them. Obey the rules of the road. Bikes are supposed to obey all of the road rules as well as cars. And if you disregard those rules, you're setting yourself for being injured by a car. Control your speed. I know I've gone much faster than I should have, and 2 of my major injuries occurred when I was going faster than I should have. That still doesn't stop me from going fast, but it's smarter to control your speed. And pay attention. Headphones and phone use on a bicycle are a real no-no. It takes one of your most important senses away from you, your ability to hear what's going on around you. Don't carry packages, and dogs with leashes they're an accident waiting to happen. Avoid high-risk riding activities and maintain your equipment. Cities can be really, cities and counties can make a big difference in whether we ride safe or not. Probably one of the best cities for bike safety is Portland, Oregon. They have gone out of their way to separate bikes, cars, and pedestrians. They have separate bike paths, they have separate pedestrian areas, and they have separate car and train avenues. It's important to have spaces for bikes to stop at stop signals, and it's really important to have bike-friendly signals. A lot of cities just ignore this. And it's important to enforce traffic laws. And one of my pet peeves, in order so that you don't get your bike stolen, it's really beneficial to have secure and protected bike barns for people to store their bicycles. And finally, drive like the person ahead of you on the bike is your son or daughter, and ride like the cars or ambulances carrying your loved ones to the emergency room. And by all means, wear a helmet. Thank you very much.